Return to play after Achilles tendon rupture. So really, the great thing about working with Achilles tendon, they're easy to see, they're right there. You have two really cool injuries. You have the overuse injury that's problem in one way, and then you have the really cool injury with a rupture, and the rupture patient have not had symptoms before. I still think that, and my patients don't cross. We've done RCTs for both patients when I was in Sweden, and those are not the same patients, which is very interesting. So it seems like the rupture are not the ones that have symptoms. When you say never, of course, you have one or two patients that have had symptoms before. But so how will this talk affect your knowledge and practice? I want to put this more, what are the issues? What parameter limits the recovery? How do we know if an athlete has recovered? Is full recovery realistic prior to return to play? And is fear affecting the ability to return? And I'm actually going to leave some of the things up because Maurizio is going to have a great example for the absolute return to play. So Achilles tendon rupture, I just like putting these pictures up, they're really cool. So ruptures occurs during sport. A lot of times it's middle-aged individuals, but actually elite athletes are younger than the general population with ruptures. One other thing, and then Marie Lundberg was talking about that yesterday, is when they're relating to fear of injury too. They do have a lot of fear of injury. So when we're looking at return to play, we recommend that they should be able to return to running and jumping in non-contact sports week 16 to 24. Doesn't say anything, right? Preliminary results from a systematic review that we've just working on. We got 102 articles. It was case series, anything to kind of look at what people do after ruptures. And 20% of those reported something in return to play. Of those, there was a weighted percentage of subjects who returned to play was 73%. But there are large variations. But there's no consistent return to play definition. And often return to activity is reported, but not the symptomatic state or their performance level. And the interesting thing is we see similar rates between surgical and non-surgical treatment, with the range from return to sport is from 29% to 87%, regardless of treatment. So one of the big things for Achilles tendon rupture, I think, is really the fear of injury. Or I think the injury is such an impact on them that they have this pain memory or injury memory that sticks to them that they have a hard time to overcome. So one of the study by Mikael Möller from Gothenburg too, in his thesis, at 8 weeks, 84% wanted to return to sports. At 1 year, 54% returned, 30% had the ability, but not the ambition. And they often get the comment, I'm not returning to the sports and I got injured. I might play basketball, I'm never playing football again because that's when it happened, which seems not very smart. But I have some videos that I want you, and I want you to really listen to this. Not the F word, but. Do you hear that? That is his ankle rupturing. You can imagine, quickly, he had no expectation, bam, and something happens. No wonder he has fear of that happening again. Here is our soccer player. There it happens. Do you see who it is? It's Beckham. It comes back and doing it in slow motion. They all surprised. When you see it again for him, look at his surprise and looking behind himself. They always think somebody hit him. And you can actually see the tendon rupture if you look at it. There. I like the awe. Here's my sport. They're going to give me a lot of good patients. Box jumps. See the jumping? She's one of the best CrossFit athletes, actually, right there. She's like, what was that? They're actually going to go around and look at the box. They think something hit it. Look at her. She can move the foot. She has still no idea what happens. And look at her walk. She has no control of the tibia over the foot. She goes over, something hit me. No, there's nothing there. Something did happen. And then she tried to walk, and she's like, I can't do it. She actually ended up continuing the CrossFit competition. I don't remember how she finished, but she had a boot on, and she was doing all the other stuff. So fear of movement, and Marie talked about this yesterday. There is actually a correlation with the fear of movement and patient-reported outcome at 3 months after. The more fear you have, the less you have, the more symptoms you report, the more of a problem you have. And we think, and what we're working on now, is maybe that if you have less fear, you're more active early on. The more active you are early on, the better mechanical loading you give to the tendon. And that's something that we're doing research on at this point. But back to the return to sports, I don't want to do the rehab part, is if you look at American football, with the NFL, you looked at Achilles tendon ruptures. You had an average age of 29, which is a lot younger than for regular ruptures, 35 to 55. but they're a little older than the average football player. 32% of the players that had a rupture never returned to the professional level. And of those that returned, there was a 50% reduction in performance. And they actually looked at videos and see how well they played and those things. Look at basketball players in NBA. Average age was 29.7 years old, but it was same as average age of basketball players. 39% of the players never returned to the professional level, and a significant decrease in playing time and performance. And good for business, sad for NFL football, there's been a lot of Achilles tendon ruptures this fall. Everybody sends me the links to the videos of when it happens. And I think I'm wondering what we're doing, or are we just training everybody more? Are we just loading more? Is that what's happening? So the interesting thing with rupture is full recovery realistic prior to return to play. We see gait abnormalities 2 years after injury. We see deficits in calf strength. One of the things that we've done research on, and we really see a lot more, is the tendon elongation is the problem. All tendons heal in an elongated position. Even if you have surgery or non-surgery, the tendon gets longer. And this is something that we're working on. I'm not going to talk about that today, but that probably occurs within the first 8 to 12 weeks, and that's might be we have doing more things with that. But at this point, surgery is not better at preventing the tendon from getting too long. It's part of the healing process. This causes disproportionate weakness in end range of plantar flexion. You see deficits in heel rise endurance. And what we've seen when I did my postdoc was that heel rise height correlates with degree of tendon elongation. So what you can do in your clinic when you have these patients is actually to see how high their maximal heel rise height is. And when you're looking at this, we can see that the mean of recovering the height of the other side is 77% or 81% non-surgical to surgical, not significant difference. But look at the other one, the mean and the max. Some people are doing horribly, but some people doing really well. So my goals for my next 10 years of research is to make sure that everybody end up in the well range, because I think we can do a lot better. We also do measure tendon elongation. We see differences from up to 5 centimeters side-to-side difference in the tendon length when we measure to the gastroc. We did another study looking at tendon elongation and muscle activity during gait. And we had the injured tendon was longer than the healthy side. So basically we looked in healthies too. There's no significant difference in tendon length between the right and the left side in healthies. However, the variation between people is a lot. And it's not that taller people have longer tendon and shorter tendons. It varies. We can have really long people with short tendons and those things too. So that's what we always compare to the healthy side. But when we were looking at walking, the calf muscle's ability to contract was not reduced during walking. So it's not like the gait problems was not related to that the muscle wasn't working. The muscle was actually trying to compensate for the elongated tendon. So it tried to account for the additional tendon slack before the motion is produced in the joint. I call the active insufficiency. So what we've looked at, we had one case that was one of those happy moments, right? I have a Achilles tendon rupture, a girl playing football or soccer, that was came in, she's 23 years old, and she came into my rupture study when I was at University of Delaware, and I was going to do running and motion analysis and explaining the EMG and the markers. She's like, oh, I've done this before. I'm like, oh, when did you do that? Oh, I was across the hall and did a running study. I'm like, ooh, when did you do that? She ended up doing the running study a month before she had the rupture. So we actually had pre and post data. The post data is 1 year after she considered herself fully recovered. So when we looked at her, she had a 4 centimeter longer tendon on the injured side. She had differences in the active plantar flexion range of motion, not very much in the dorsiflexion range of motion. The heel rise height was different, 5 centimeters. And she has some strength deficit. When we looked at the running biomechanics, we could actually see pre-injury, she had an increased peak abduction of the foot compared to the uninvolved side. And one of the thoughts that we're having is if her tendon, she didn't have symptoms beforehand, but if she had a more compliant tendon, that might have caused her to be actually stretching it out more with the same load, and hence the more greater peak abduction. And that could have done more of a diagonal load of the tendon and by predisposition her to rupture, but we don't know. This is the case that we have. Afterwards, we see post-injury, she had even greater eversion and abduction that we think might be related to having this longer tendon. The other thing that you're going to see down below too, she actually increased power absorption in the knee. So she was compensating a lot of the load that she couldn't generate in the ankle or absorb in the ankle in the knee. So we started a Swedish-American Achilles tendon rupture biomechanical study. It's with my PhD student Anneli Brorsson in Sweden, Roy Tranberg and Rich Willie in the United States. And this is just preliminary data that I just have, and we're actually going to present at the CSM meeting in the United States in the spring too. But the black bar are patients that had 20% heel rise height difference at 1 year, and the red and white are those that was below 30%, so it had greater than 30% difference at 1 year. And this data is collected at 5 years. So we looked at the data 1 year, we called the one that was on the top and the ones on the bottom and see is the biomechanics and the difference 5 years later on. And these are just some of the data, but you can see there's significant differences. So if you didn't recover the heel rise height as well, you have decreased Achilles forces, you have decreased eccentric plantar flexion power, decreased concentric plantar flexion power. In single leg hopping, same thing as drop vertical jump. We also see it in running. And this is just the ankle. We have a lot of knee data too, and what we see is that what you don't do in the ankle, you're trying to get to in the knee. So the question is it safe for them to return to sport? Can they return to sport if you can't do anything about the tendon elongation at a later date? And I think that I discussed with several people for these 2 days that maybe they never will return. They're not going to return the tendon elongation. Should they go back in and make it shorter? It's another year of rehab. Do you want that? And what we're really trying to figure out which ones are going to do well and which ones are not. But also the sports, the ballet dancer that has problems with heel rise height, they are the ones that have to stop. They can never go back to be a professional dancer. They cannot get up. For them, it's very crucial. Skier, it's really put them in the boot. Who cares how long your tendon is? You can probably function very well and do it anyway. Team sports, maybe you function a little differently. You compensate. So then you might need to consider what are the other aspects. Do they have a lot of hip problems, knee problems? Do we need to look at these things if they go back with an altered biomechanics? I don't think the altered biomechanics is something to tell them not to go back. And I just put the sailing picture in there because it's really cool. It's called a moth. That's because most people think sailing is something not very athletic, but my brothers sail this both. They're weird. So the other thing is, can we compensate for altered tendon length and mechanical properties? So this is the next step maybe. So you have this problem, a little longer, Achilles tendon, if you got the strength going, what can you do? You know, our shoes things, we're trying to look at, and Rich Willey in the US and East Carolina University looking a little bit, can you do, you know, minimalistic shoe, should be a little support, should there be rocker surface, are those things, is something there that we can help them with? Is there any other equipment, taping them, might that help, some of the loading and things? Or is an external tendon, I work with, they do a lot of prosthetic devices, and there's actually some external tendon they put on military and things to try to support, maybe we can have external tendons. I don't know. But load control might be something too. So if this is a patient with a previous rupture, they're doing well in the sports, if they develop a knee problem or other things, you might consider that this might have something to do with it. So in summary, we want to minimize the occurrence of tendon elongation. It's of great importance, but that's a whole other talk, and we're working a lot on trying to figure out what are the parameters for that. Tendon elongation causes permanent deficits in ankle plantar flexion power, generation, and absorption. Other joints, tendons, muscle might compensate for loss of Achilles plantar flexion function. Full recovery of triceps sura to pre-injury level might not be a realistic goal for all. It used to be at University of Delaware when I came in the program, it said that the goal was to have 90% of the heel rise height of the healthy side before they returned to sport. And I told them, you're not going to have anybody to return. Obviously, nobody listened to that criteria because they have people return. So don't have unrealistic expectations. I have patients coming to me, I need to train more, and we do full test battery, and we can see, is it the muscle problem? Are they weaker, or is it a length problem? We do the heel rise height test. That gives us a really good indication, because if they come almost the same, but their work or the number of repetitions is a lot less, it's probably more muscular, and they can do a lot more training to get better. You might also have to alter what position they do the training in. They might actually have to start in more of a dorsiflex position to get that muscle to really generate enough force, because if the muscle doesn't generate enough force, you can't build up the strength. Might need to adjust performance, sports dependent. Fear of re-injury might affect return to play. So the clinical implications, control progression in each phase of rehabilitation. But I don't need to talk to this, but Maurizio is really going to cover this excellently. I just want to thank all my collaborators, the people in the Swedish-American Achilles tendon rupture biomechanical study. We just wanted sobs because that used to be a Swedish car. And thank you.